So we're going to go over the importance of interpreting the angiogram to plan and complete coronary intervention in CTOs. So I want to go over how to do a dual injection angiogram, what we're looking for, and how we use this to strategize a CTO intervention. So this is a basic talk, but I think it's very important because this is the bedrock, the cornerstone of doing these procedures successfully. This is a hybrid algorithm, which most people are quite familiar with. There are 4 parameters of the hybrid algorithm. First of all, step 1 is the dual injection. So that's what we're here to talk about. But there are 4 parameters, anatomic parameters, that are outlined in the hybrid algorithm that what we'll do is spend the next several slides going over specific examples of these. So the ambiguous proximal cap, the distal target, the appropriateness of the interventional collaterals, and the length of the CTO. So I'll show you some real-world examples of all of these and why we look at this and how that helps us plan the case. So what are the basics of the dual injection angiogram? Step 1, low magnification, 10 inches, 25 centimeters. Inject the donor vessel first. Give time for the distal bed to fill before you inject the actual CTO artery. Avoid panning if at all possible. And wait for the contrast to clear before you step off the cine, because sometimes you'll be surprised at how short the CTO actually is if you just give it a time to fill. So, this is how I was taught to do an angiogram when I was a fellow. And this is not meant to be disparaging of the operator that took this angiogram, but this patient was referred for CTO PCI. This is not how you can do this case. You cannot plan this case out using this angiogram. And this is meant to illustrate how much more information you can get if you do the angiogram the way that I just outlined. So you inject the donor artery first, wait for the distal bed to fill, then inject the CTO vessel, stay on cine long enough to see exactly how long the CTO is. This gives you all the information to plan out the case. This is another example. This is a patient with an RCA CTO where the operator was actually able to cross with a guide wire and then had difficulty advancing microcatheters and balloons. And ultimately, they ended up bailing on this case only because they were concerned about exactly where their guide wire was. There was no attempt to do a dual injection. They simply bailed and referred them on, which is probably the right thing to do at this point. Patient was brought back to our institution, did a dual injection angiogram to define the length of the CTO, and basically we followed the path that the first operator created. We advanced the guide wire, did the dual injection to confirm that we were in the true limb and distally, and now we're very, very aggressive with the proximal cap, and we're able to cross after laser atherectomy and balloon dilatation and stenting. So let's get into the specifics. So this is an example of a very favorable proximal cap, very tapered, very, very short CTO. So this is the ideal proximal cap for an antegrade attempt. And in contrast, this is a patient with a relatively ambiguous proximal cap. You can see all kinds of epicardial collaterals, bridging collaterals coming off the cap. Hard to know exactly where to puncture, but a relatively short CTO, so still maybe worth an effort. There are other things you have to take into account. So this is a patient who you can't tell. Just can't tell where the cap is, what's going on. It's very helpful to just stop, play it back frame by frame, and you can outline exactly where the path of the artery is, and it's essentially a functional CTO. It's not even really a CTO. It was just a matter of taking your time to plan the case out, frame by frame playback. This is another issue that you had to take into account. This is a patient with sort of a blunt cap, side branch, unfavorable, and also a lot of tortuosity proximal to the cap. So this may make it difficult to advance equipment to have the adequate support. So these are things to plan for as you perform your intervention. This is a patient with a very short, blunt proximal cap and a side branch. And in this case, we use the side branch to perform, just to add support to do the case, because there were no retrograde options in this situation. This is a patient who has a blunt cap, side branch, and unfortunately it probably doesn't project very well, but a high level of calcium at the cap. So also lots of unfavorable features, but things that need to take note of as you plan the case out. This is a patient where I brought this case really just to show you how important it is to stay on cine long enough. You can see if you stay on long enough, this is a really short CTO. It took a pilot 50 to cross this thing and we were through. So it behooves you to take your time to just stay on the cine pedal long enough to really understand what's going on. And in contrast, this is a patient with a super long CTO. This is almost an osteo RCA CTO. So certainly not something that you're going to get with an antegrade wire. But what's good about this same case is if you look at his distal cap, this is the next parameter that we look at, is the quality of the distal cap. There's a lot of healthy right coronary artery proximal to the crux of the right coronary artery. So this is an excellent target for subintimal dissection reentry, which I show on the right panel. We're able to preserve both branches of the right coronary artery without any real concern of jeopardizing either branch because there was such a nice landing zone. So this is just a nice example of septal collaterals. I'm afraid to touch this mouse, but I think we should. So what I do for these cases, Stefan, maybe you do it for me. I like to actually play it backwards until I see the donor vessel fill the PDA. So if you go forward to right about there, so that's where you first see the PDA fill. So you can follow that first septal perforator all the way back. And then if you play a few more frames forward, you'll see that there's a second septal perforator that also supplies. And then at the end, you see an epicardial collateral at the apex. So this gives you good confidence that there are multiple routes of collateralization. So you can occlude one of these septals, and hopefully the patient will tolerate this well because there are multiple sources of collateralization. But playing these frame by frame, forward, backward, it often can help you plan out these cases and figure out what's the most optimal collateral to target. These are examples of what I call relatively friendly epicardial collaterals. We've always all talked about how much riskier the retrograde approach is, and certainly epicardials even add additional risk. These epicardials are relatively large caliber. They're tortuous, but not super high frequency tortuosity, so these can generally be approached with relative safety, as opposed to this epicardial. This is a very high frequency tortuosity, very small lumen, probably not the best one to try to wire. And let's not forget about vein grafts. Occluded vein grafts, patent vein grafts, all of these can be used for retrograde conduits. This is a patient with an anomalous right coronary artery where we went down an occluded vein graft to perform reverse cart. And then also there's other issues. There are patients that have multiple features. So this is a patient with a blunt proximal cap, side branch. The distal landing zone is very poor because of a bifurcation. So you have to take into account all of these as you plan the case out. This is a patient who has an occluded vein graft at the crux of the right coronary artery, and the retrograde wire, it would just go up the vein graft. So we actually had to advance an antegrade subintimal wire simply to aim at to perform a retrograde knuckle and get up the right coronary artery. So sometimes it's not the angiogram, it's just having a guide wire in position to aim at. But these are all little tricks to try to get the case done. So in conclusion, the dual injection angiogram is really critical to maximize your information for CTO PCI. You have to allow adequate time to review the angiogram in order to strategize the case. And as a final tip, frame by frame and reverse playback can be very helpful to really maximize your understanding of what you're looking at.
Very good. Right. Thank you. Go ahead. So